like she said, my name is Heather Burks. I'm one of the reproductive endocrinologists in the Department of OBGYN over OU. And so the two topics we're going to be going over today are actually quite a bit of the meat and potatoes of what I do clinically. So we're going to talk first about infertility, and then we're going to talk, which covers polycystic ovary syndrome somewhat, but then we're going to talk in a lot more detail about polycystic ovary syndrome because unless you take care of exclusively people who are much later in life, there's a very high likelihood that you'll see, women or men who are part of a couple that's experiencing infertility. And if you take care of women at all, you're going to see PCOS. And it actually takes a lot of women, multiple different providers, to have someone actually establish the diagnosis. And so you can be knowledgeable about at least, what to look for and what are some good initial steps to take with the workup, then you might be that one that figures it out. So we'll start with infertility. So we'll just go through kind of define terms, talk about normal fertility, including tips on how to counsel patients who are not infertile but tell you that they're just starting to try for pregnancy, and then talk about common causes of infertility, treatments that are aimed at each specific cause, although to be honest, there are a lot of couples in my practice that have more than one of the causes. And then indications to refer to a specialist, which, kind of depending on how often you see it and your level of comfort might be when they come to you with the initial complaint, because we can certainly do the workup, or after you've done some initial evaluation and know that they need treatment that you would provide. So we'll talk a little bit as we go along about what a fertility specialist can offer. So infertility technically is inability to achieve a pregnancy among a heterosexual couple that's been having 1 year of unprotected, decently well-timed intercourse, and we'll talk about what we mean by well-timed intercourse. Fecundability is, by definition, the probability that they'll achieve a pregnancy within one menstrual cycle of trying. And fecundity is a chance that they'll have a live birth in a single cycle of trying, which are not the same thing because not every pregnancy that's established is going to continue on to deliver a baby. So I'm told you guys have gotten into normal menstrual cycle somewhat, but I just wanted to highlight a couple of the themes that are going to come up throughout the lecture. So, typical time period, we think of normal menstrual cycle being every 28 days, but there's obviously a range of normal. But so that 28-day cycle, we assume ovulation is going to happen on about day 14. So that follicular phase where they're developing a follicle, getting ready to ovulate, is going to be about that 14 days. And then the next 14 days is going to be the luteal phase, where now their ovary has a corpus luteum in that same spot that released the follicle. That's going to be making progesterone, kind of getting the lining ready for hopefully an implantation. And then if no implantation occurs, that corpus luteum's lifespan is only those 2 weeks. It's going to go away, therefore dropping the progesterone level, and then they're going to have their period. And then go briefly to normal anatomy of the female reproductive tract, just really basic. So the ovary tends to sit over here, kind of in the vicinity of the fimbriated end of the fallopian tube. After intercourse, sperm gets deposited here in the posterior fornix of the vagina and has to trek all the way up through the cervix, cervical mucus, through the uterus, and then out into the fallopian tubes, and whatever side that, whatever side that egg has gotten released from, it'll get picked up in that fallopian tube, and fertilization actually happens out here in this portion of the fallopian tube that's called the ampulla. So for couples who are first starting to try for pregnancy, we know that actually more than half of them are going to achieve pregnancy within that first 3 months of trying, so 57% at that point, and then a few more will if they continue to try for 6 months. An even smaller number more will after 1 year, and so after 1 year of trying, we expect that about 85% of couples will have achieved a pregnancy. So that other 15% of couples are going to be diagnosed with infertility. So what I mean by well-timed intercourse, the fertile window of your menstrual cycle is really that 5 or 6 day period of time leading up to the ovulation. And so we know that sperm can hang around in the female reproductive tract after intercourse for a period of up to 5 days. If you get even closer to ovulation, and I'll show you guys a graph in a second, those are probably even higher fertility days, but once that egg is released, the next day and beyond, no chance of pregnancy. And so people will actually track their periods to sometimes do the opposite, where after your ovulation is passed, if you're trying to avoid pregnancy, that's an okay time to have intercourse. But for my couples who are trying, that 5-6 day window leading up to the ovulation is probably the best time. So we'll talk a little bit about how they can tell when their ovulation is happening at home. But if they're not sure and it becomes challenging to predict, then just knowing that, for that week and a half after they finish their period, they probably want to aim for intercourse every other day. They'll probably hit that fertile window. But so on this little graph, day 0 is the day of ovulation. So for women who are younger, and so they've got this stratified by yellow line is 19 to 26-year-olds. I'm sorry, that's tiny. And then the blue line is 35 to 39-year-olds. So as you can see, difference in pregnancy chance based on female age. But the pattern stays the same as far as like when should intercourse happen within the menstrual cycle. And so the 1 or 2 days before ovulation are probably the best, but we have documented pregnancies from a single episode of intercourse as many as 6 days before that ovulation. So, home ovulation monitoring, that's a frequent question that I get, although a lot of my patients have been working on this for a while, so they've done a lot of reading. Basal body temperature monitoring is one method. In order to do this, you either need a graph that has sorry, this is also tiny, but you need a graph that has temperature on that y-axis, basically by a point of, this is showing Celsius, but most of them are going to be in Fahrenheit. Apps can do it, but the patient has to be really consistent about which time of day they take their temperature. It does matter. It needs to be before they have any activity, so they need to literally wake up and remember to take their temperature before they start doing anything for the day, including getting out of bed. So you just keep it by your bedside, you wake up, check your temperature, put it in your app, or you document it on your little chart. And so the reason this works to show ovulation is because your body temperature is going to rise by about 0.2 to 0.4 degrees Fahrenheit after ovulation, because that progesterone production, having progesterone in your circulation, raises your temperature just a little bit. And so we know that once you have had that ovulation, your actually temperature drops a little on that day, but then will spike upward. So we can look at this graph for the whole month and tell that this patient had an ovulation on about day 14. So it's nice for somebody who doesn't already have infertility, knows they're going to be trying in the future, wants to kind of know what days of the month they really need to aim that fertile window. So urinary LH kits, are also called ovulation predictor kits, are available over the counter, most grocery stores, drugstores, pharmacies. So they come in a couple different varieties. So they can be digital, like this one is, where there's a little window that shows you an empty circle if it's negative and a smiley face if it's positive, or you can read the lines yourself. And so I always explain to patients, this one behaves kind of like a pregnancy test, but it is different. So, with pregnancy tests, I think most people are familiar, you have a possibility of 2 lines, but 1 line is negative, 2 lines is positive. That is not how these work. They're a little different. So often there are always 2 lines, and then it's positive when that second line, the test line, becomes as dark or darker than the control line. And so they're cheaper to do that way, but might contribute a source of stress if they're having trouble, feeling like they can judge which line is darker. So I kind of let patients, if they're going to use these, pick which type they want. And then there's even fancier digital kits, which will start linking at you when you're getting close, but then they're positive when you get the real smiley face. And so you're checking estrogen too, and showing you when the estrogen goes up, because that'll happen a few days before ovulation. So lots of choices there, lots to understand. A lot of the boxes to actually tell you to check your predictor kits at a different time of day than what I want my patients to do it. So early part of the afternoon is the best time, and a lot of the instructions on the kits will say first thing in the morning. It's just, you're more likely to get a false positive when your urine's more concentrated, so I don't have to do it that time of day. And then, so cervical mucus has been cited as maybe being a better way to track your ovulation than some of these other things, but I will say clinically it's kind of challenging. So when you're checking cervical mucus, you have to have a patient who's actually willing to go and get some mucus from their cervix and put it on their finger. But when you're about to ovulate, it's supposed to have this characteristic where, just as shown in this picture, when you spread your fingers, it makes a little thread between. So there's a fun German word for that called Spinnbarkeit, and it just means thread-like. And so when it gets to that point where it doesn't snap between your two fingers and makes a little thread, then that's supposed to be when your ovulation is happening. That's your fertile window. I don't usually encourage this either because there's a huge amount of variability between people. And then there are lots of apps for your smartphone. Everybody trying for pregnancy has one of these. They probably don't work super well to tell you your exact day of ovulation, but I like when the patients have that because they can at least tell me when their exact, first day of their last menstrual period has been in their previous menstrual period. And so I get a really good menstrual history when they've got that. So I kind of like it for that purpose, but it's not as good to tell you the exact day of ovulation. But it can kind of give you an idea because you know that you're going to have ovulated about 2 weeks before you have your next period, so you can kind of look back and see what cycle day that happened on. But these things, taken all together, maybe inaccurate up to 50% of the time. So, but they certainly help people to feel like they're being proactive, and that's not nothing. So, I get asked frequently as well, should we have intercourse every day in the fertile window, every other day? My answer to that is it probably doesn't matter, because the research shows it probably doesn't matter. But it's probably better to aim for at least every other day than like once a week if you're really actively trying for pregnancy. At least in, as best you can tell what your fertile window is going to be. And then with certain types of fertility treatments, I can tell the patient exactly what day they're ovulating because I know I made it happen. And so, with that I can usually say, okay, these 3 days are your best days, and I'll tell them to do daily within those 3 days. But if you're trying to aim for daily intercourse for like 2 straight weeks, that is stressful for people, and I don't really want to pile on. Infertility is already a very stressful diagnosis to have. So if they're taking a medicine to ovulate, and I think it's probably going to be around some specific week, but I don't know exactly, and we're not monitoring them with ultrasound or anything, then I'll just tell them every other day intercourse for about a week and a half. So, other questions? Do I need to be in a specific position after sex? You do not. So sperm are actually able to get into the female reproductive tract pretty quickly. People always ask when I stand up, it leaks back out. That's supposed to happen. Only the sperm cells are supposed to get past the cervical mucus. The liquid part does not, so it's supposed to come back out. That is normal. Female orgasm might promote sperm transport, but there's no correlation between that and actual pregnancy chances either. Lubricants. So I showed this slide with a caveat. None of this is actually like in couples actually using the lubricants. This research that we have, it's in, if we put sperm in with the lubricant in the lab, did we impair the ability of the sperm to swim? So it may not totally correlate, and I doubt for somebody that's been trying for a year, if they've been using the wrong lubricant, there's no way that's the whole problem. But in general, we say avoid, a lot of the over-the-counter lubes like Astroglide, KY, and then actually like olive oil and saliva. Those things can all inhibit motility. Instead, kind of depending on your budget, there are some over-the-counter kind of conception-minded lubricants that haven't been found to impair sperm motility. So they have cheeky names like Pre-Seed and Conceive Ease. And for people who are maybe on a little bit more of a budget, actually canola oil should be fine, and mineral oil as well. So diet and lifestyle. So I have this conversation with people a lot about high BMIs and longer times of pregnancy, and in some cases BMI can be so high that it can make them anovulatory. So BMIs outside a normal range. And actually really low BMIs can even quadruple the amount of time it takes a couple to get pregnant naturally. Smoking increases rates of infertility in couples. High alcohol consumption, meaning over 2 drinks a day, increases infertility in couples. Illicit drugs, in particular, methamphetamines, cocaine, marijuana, not as much. can increase infertility. Exposure to toxins at work, so that can be things like, do you work for a dry cleaner, agricultural workers, exposure to heavy metals. And then high caffeine consumption is a little more controversial, but we usually have people just consume caffeine in moderation, because certainly I don't want you doing that in early pregnancy. And then making sure women are taking at least 400 micrograms daily of folic acid, so that when they do achieve pregnancy, they'll decrease their chance of femoral tube defects. So we do all this like preconception counseling, staying away from seafood that has high mercury content, so not tuna every day. Quit smoking for both partners can affect female infertility. We think it may impair the ability of the fallopian tubes, their little cilia that are inside, to actually like sweep eggs and sperm where they need to go. And for men, it probably decreases sperm motility and morphology. Morphology being the shapes, we'll get into that in a minute. But so again, caffeine kind of in moderation, no more than, I usually say 1 or 2 cups of coffee a day, like normal sized cups of coffee, not your big like Starbucks and even 8 ounce. And then alcohol, avoid in early pregnancy, and so if you're trying for pregnancy, probably avoid while you're waiting for your pregnancy test. And then, so female aging, it just is what I mean by this slide. So this is actually showing a number of different populations for which we have really good like marriage and birth records, but a lot of it's kind of before we have the advent of fertility treatment. So there's several different time periods of Hutterite populations, and like the upper class people of Geneva in the 1800s and things like that. So we've got these populations where we can say, you know, age of the wife, because they only looked at married couples, and then what was the pregnancy rate per 1,000 wives. And so you can see just naturally this hangs out pretty steady until you start to get closer to 35, and then from there it's going to decline until there are hardly any births past late 40s. And so that's part of ovarian aging that we're going to discuss. So for females, we are pretty much born with all the eggs we're ever going to have, and then the total number of primordial follicles actually peaks prior to birth, and then starts declining before you ever hit puberty. May go from as many as 2 million follicles when you're born to 200,000 follicles when you even start menstruating, and then is going to just naturally decline from there. And so there have been several efforts, including a couple that are newer than this one. This was published in '98, but just showing what we think happens to the follicle pool over time, and as the pool starts to drop, that's when you see the end of what we consider like the real fertile lifespan, so probably around 41, 42. Beyond there, fertility rates decline dramatically, and then between 45 and 51, that's for women who are at least on like an average trajectory, you start to become perimenopausal, so they're starting to go through that perimenopausal transition, starting to have some irregular cycles, and then they'll often have their final menstrual period at age 51 or 52. And that's when the follicles are done. So with age, so pregnancy rates decline. Fecundity, again, is that chance of delivering a baby in any given menstrual cycle. And it's not as high when you're in your early 20s as I think people presume that it is. It's about 20-25%. And so then declines steadily throughout our reproductive life. And then as that is happening concurrently, if you do become pregnant, the risk of miscarriage starts to go up, particularly in your late 30s and early 40s. And so we think the same process is helping to drive those two things. So those follicles that have been sitting in there in the ovary, kind of waiting to ovulate for however much time, are actually arrested mid-meiosis. And so they're arrested at a stage where you've got your spindle formation, it's ready to pull half the DNA into the polar body and half into the egg. And we think that one of the contributors to this is that that spindle is going to degrade over time, and so the ovulations that you have later in life are more likely to have a spindle that didn't actually pull half and half. So you might have 2 chromosome number 21s, for example, that stick together, both get pulled into that egg, nut get kicked off, sperm comes along with a third chromosome number 21, and that's trisomy 21, which everyone's familiar with as being Down syndrome. That can happen with any of the chromosomes, or you can have a missing chromosome, or you can have some combination of some are extra and some are missing. And so that aneuploidy rate, where it's any number of chromosomes other than that normal 46 euploid, that's either going to be just not pregnant for the month or an early miscarriage, and the rate of that happening just goes up and up and up, in particular starting around age 35, so that's a lot of what's driving this. So that's important for patients to understand when they're coming in those age groups. So for female side, basic fertility evaluation is going to include, and we'll go through the details of all of this, history and physical, assessment of their ovarian status, so that's ovulation plus ovarian reserve testing, getting a sense of how their follicle supply is doing, checking for uterine abnormalities, checking for fallopian tubes to be open, male fertility testing is part of it as well, and then that preconception counseling that we were just talking about, where we optimize our medical conditions, medications, and lifestyle. So the history and physical is going to be super detailed. It's all the usual stuff we want on an OBGYN visit. So plus some extra things that I might care about a little bit more. So I want to know, like, how long have you as a couple been trying for pregnancy? What workup have you had previously? I want to know your menstrual history. Again, that's why I like when patients have that app, and they can really tell me when their periods come. But I want to know, is it around the same time each month? Can you tell when your period's coming? Do you tend to get what we call those maliminal symptoms, right, where you might get some weakness, some breast tenderness, some crampiness even before you have the bleeding, because that is a good sign to me that they are having bleeding because they ovulated. Women with anovulation can have periods sometimes, but they don't usually have those symptoms. They usually just hit you all of a sudden. You had no idea you were about to get a period. It could come anywhere from 2 weeks after your last one to 6 months after your last one. There's a huge variation. So around the same time each month, around the same number of days of bleeding each month, comes with cramps and other things. That's a good sign of ovulation. Pregnancy history, have they had pregnancies before? What happened with those pregnancies? Did they miscarry? If so, did they need to be treated with a PNC? Did they need fertility treatment when they conceived before? Was it with the same partner, or do they have a new partner now? And since being with this new partner, they've had this fertility problem. GYN history, I care about their history of STDs, in particular chlamydia, gonorrhea as well, but those can lead to pelvic inflammatory disease. And even without having full-blown pelvic inflammatory disease, they can absolutely lead to inflammation in fallopian tubes and cause scarring, so it's a huge risk factor for tubal blockage. What methods of contraception have they been using in the past? Most types of contraception, when you discontinue them, they will be out of your system pretty quickly, shouldn't persist and cause infertility, but there's an exception to that, which is Depo-Provera. So, it's FDA approved for contraception for 3 months following your IM injection. It lasts in your system quite a bit longer than that, and it's variable. So for many women, it'll last at least 6 months, their last dose, and I've seen it go beyond a year before. And so if you've got a patient who wants to contracept for a little while, but next year they're going to start trying for pregnancy, Depo is not a good choice. They would probably want to use like oral contraceptive pills, because those, once you discontinue them, your next month you should have normal fertility if nothing else is going on. So we talk about frequency of intercourse, whether there's any sexual dysfunction, past surgical history. So in particular, with that, I do want a full history, but I care about prior DNCs, because that can cause some acquired uterine scarring that can contribute to infertility. I care about whether they've had prior laparoscopies for endometriosis, because that can cause scarring in the pelvis, and that can lead to tubal blockage. I care about whether they've had a cyst removed from their ovary because it ruptured. That can cause some inflammation. I care about appendicitis, because that can actually contribute to an entire area in their lower quadrant here of scarring, and so it could block, in particular, right tube, but could also block both. Past medical history, so again, in general, but in particular, I'm specifically asking people about, like, have you ever had problems with your thyroid? Because thyroid dysfunction can contribute to anovulation. I care about galactorrhea in my patients that have irregular cycles. I care about hirsutism and dyspareunia, which is that painful intercourse symptom that can come along with endometriosis as well. So is this somebody that I need to be worried has endometriosis, which, as I mentioned, can cause blocked tubes, but it can also all by itself contribute to infertility even if tubes are open. Medications, I want to make sure they're on, medicines that they'd be able to continue safely in pregnancy. If they're managed for hypertension, I don't want them off an ACE inhibitor. I need to swap them out for something else. Family history, so in particular, we tend to ask about other female relatives that have had reproductive failure or early menopause, and any relative that has had a history of birth defects, like could they carry something genetic? That's part of preconception counseling, not fertility as much, or in particular male relatives with mental retardation, because if that's caused by Fragile X syndrome, then this patient might be at risk for going into menopause early herself. And then social history, again, all those exposures we were talking about before, and if there's anything we can remove exposure-wise. So physical exam is with all those things in mind. So your typical, get your vital signs, do your full exam, check for thyroid nodules, a breast exam, in particular checking for secretions, but also nodularities, signs of androgen excess. So for women, the places that they tend to get hair growth that could be because of an androgen excess. We'll talk about a little bit more next time, but they tend to be midline, so it's like lip, chin, neck here between breasts, around the belly button, inner thighs, and low back. So it's this midline hair. And terminal hairs are these darker hairs that have that darker pigment the way that like eyebrow hairs would, that wider shaft. So ovulatory dysfunction accounts among like female contributions to infertility. It's a little over a third of the time, about 40%. For infertile couples in general, probably contributes to about 15%. This is a fairly common cause of ovulatory dysfunction. Like I said, we're going to get into PCOS in a little bit more detail next hour, but I see a lot of that as even sole cause of infertility. But it's not the only reason you might have ovulatory dysfunction. So obesity all by itself can contribute to anovulation by all that extra adipose tissue changing your hormonal environment. Swinging in the opposite direction, somebody who has a calorie imbalance, so they're a strenuous exerciser, maybe expending more calories on a regular basis than they're taking in. Their body may react to that by increasing their cortisol, which is going to shut off their hypothalamic pituitary ovarian axis, because whenever your body is stressed in that way, it's not focused on reproduction, so you may just totally stop having menstrual periods. As I mentioned, thyroid dysfunction, and that can be hyperthyroidism or hypothyroidism, both can cause menstrual dysfunction, and then hyperprolactinemia. So we talked about that menstrual history that tells me that you are ovulatory. And if I've got somebody who's telling me, I never know when my periods are coming, I went 2 years without having one time, but these last 6 months I've bled almost every day. I mean, I know that person doesn't ovulate. You actually can stop there. You need to figure out why they're not ovulating, but you know that they're not. If they have kind of an interesting history somewhere in between, their cycles are 25 to 45 days, they don't really get that cramping along with it, that's the person I'd probably do an evaluation to see if they're really ovulating or not. So you can ask whether they've used home checking methods, and then kind of the most specific proof that you've got a patient who's ovulatory is if you catch them in their luteal phase, and we like to try to aim about 1 week after they ovulate. So for a 28-day cycle, that's cycle day 21. Check progesterone level, and if it's high, that means they ovulated. If you're not taking progesterone, then your progesterone is only going to be high if you ovulated within the last 2 weeks, or if you're pregnant. So labs have different cutoffs on the progesterone level. Most of them use 3. My lab actually uses 2, so you always have to check your normal values that are on the lab result that you get if you order this on a patient. So then treatments for anovulation. So Clomiphene Citrate actually isn't the oldest fertility medicine that we have. These gonadotropins are, but it's been around for a while. It's been FDA approved for ovulation induction since like 1962. So luckily, it's been generic for a long time. It's very inexpensive. It's actually on the Walmart $4 list. So if all I'm treating you for is that you're not ovulating and I can get you to ovulate on Clomid, we can probably help you with your fertility without having to spend too much money, which is nice. Not FDA approved is letrozole, which is an aromatase inhibitor, and then we'll talk a little bit about gonadotropins as well, but this one is usually my last choice, but for some patients it's the only one that will wind up working. It is quite a bit more expensive. It's injectable. You have to take it self-home injection, sub-Q, every day for about a week and a half usually. So Clomiphene Citrate is a selective estrogen receptor modulator, so it acts like an agonist in some tissues at the estrogen receptor, and it acts like an antagonist in others. And I'm actually most interested in it as an antagonist at the level of the pituitary and the hypothalamus, because that is going to make your reproductive system actually think that your estrogen level has dropped low. And so estrogen and FSH communicate with each other by a negative feedback mechanism. And so when your estrogen gets dropped in general, your pituitary is going to react to that by increasing the FSH. And FSH is a hormone that's important for talking to the follicles, picking that one that's going to grow large and eventually ovulate. And so if you've been in this pattern where FSH has never really been high enough to pick a dominant follicle, giving you Clomid can often keep you out of that pattern, get the FSH high enough, and then get a follicle to grow. And actually letrozole works in a very similar way. It just accomplishes it a little bit differently. So letrozole is actually an aromatase inhibitor. Aromatase is the enzyme that converts androgens to estrogens. And so by blocking aromatase, I'm actually stopping that progression through the steroid pathway, so they'll get stuck at the androgen phase, never progress onto estrogens, and so I'm actually dropping this patient's estrogen level really, really low. That's why this is actually FDA approved for patients with breast cancer, because you want their estrogen really, really low when they have that estrogen receptor positive breast cancer. But I'm only going to have my patients take it for a very short course, so they'll take it for about 5 days. Again, that low estrogen level is going to tell the pituitary to crank out some extra FSH. And then we stop the medicine so that once we've got a follicle selected, it can actually grow large and estrogen can start to go up again. These two have actually been compared in patients that have polycystic ovary syndrome, and I apologize that the figure is a little bit blurry, but this is basically showing in each of these graphs, the red line is letrozole and the blue line is clomiphene. And this is time to live birth. So for the entire group of patients, the time to live birth with using letrozole was actually quite a bit faster than it was for clomiphene. And so despite the fact that it's an off-label use because of this study, we've actually started using letrozole as first line for patients with PCOS. And then there's going to be some percentage of patients that don't respond to either of these. So that's probably going to be about 10–15% of my patients with PCOS. But there are other reasons for not ovulating that actually we know aren't going to respond well to Clomid or Femara. So for example, if I've got my person with that disordered eating or the over-exercising, often like I said, their whole system has shut down because it's not focused on reproduction, so their FSH and LH production in their pituitary has been really low, but actually their estrogen's been really low also. And so if I take someone with low estrogen and I drop their estrogen, maybe a little bit more, their body's not going to notice. And so they may actually not respond to these medicines that are trying to trick the axis. But luckily, we do have gonadotropins available, so I don't need their pituitary to rally and make more FSH. I can actually just give it to them directly. Like I said, the bummer about this one is that it's quite a bit more expensive. It's really effective, and with all of these medicines, there's a risk that you could ovulate more than one at a time. So it's kind of hard to control how many you actually have. It's very variable between patients. Even if you take into account their BMI, it's still super variable. And it's even variable for any individual patient from one cycle to the next. So we always have to counsel our patients, you're going to have a higher risk of twins when you take these medicines. And with these injectable gonadotropins, the risk of triplets and worse is actually like the highest of any of the fertility treatments that I offer. And so we do have to be really careful with this one. And if I get a massive over response, like I've got somebody that's about to ovulate, like 8 or probably even 5 or 6, then we tell them, you know what, we're actually going to see if we can get you to even not ovulate. We'll just start you right on some birth control, get this cycle gone, start you back on a lower dose, because it's much easier to stop this now than it is to take care of your quadruplet pregnancy. So for safety reasons, it's very unusual for us to diagnose even a triplet pregnancy, but it's very disappointing for somebody when they've spent all this money taking these medicines and then we cancel the cycle. So they have to know that's a possibility on the front end. And then there's kind of a more unusual treatment that isn't done as much anymore, but I just wanted you guys to know what it is, called ovarian drilling. So for patients who don't respond to the oral medications, Clomid or letrozole, in some cases, during this ovarian drilling procedure, which is a laparoscopy where we actually, like you can see here, just take cautery and burn the ovary in several places, that can actually help destroy some of the parts of the ovary that are overproducing androgens. And I've got some slides in the next lecture that kind of show why. But for some patients, that will help them to either respond better to the medicine or even to ovulate on their own. But that is not done as often, especially in cases where we have good access to those injectable medicines. And so then continuing on with ovary function, there are various tests that we have to look at ovarian reserve. So ovarian reserve is the very vague term that we use to talk about, is your egg supply high or is it low or is it pretty average for your age? And that's really all it tells me. It doesn't tell me, do you have good eggs? I get a better idea about that based on your age actually. But it tells me, if I give you a medicine to try to get you to ovulate or to have extra ovulations, how likely is it to actually accomplish that goal? So we use it to, help choose doses of medicine sometimes, and also for patient reassurance too. I can give somebody the answer of well, your reproductive lifespan is actually coming to a close really soon, like we've got a 30, versus you're nowhere close to the end of your reproductive years, so no panicking yet. So the different evaluations we have, menstrual cycle day 3 FSH, which has to be drawn with an estradiol level to be interpretable. You can get an antral follicle count by ultrasound, and you can get a serum anti-Mullerian hormone level at any time in the menstrual cycle. So the reason we check FSH and estradiol on cycle day 3 is because that is when your estrogen is lowest, and so it's not going to be artificially suppressing your FSH. And FSH is actually more reassuring when it's low. When FSH is really high, then that tells me that the pituitary is screaming at the ovary, and the ovary is not able to do much with it. So that's indicative of a lower egg supply. So I like to get both together. I need the estrogen to be ideally below 100. It's even better if it's less than 80. And then I'm happiest when my FSH is less than 10. But this one's kind of a tricky one to get because you do need to catch patients on that 3rd day of their menstrual cycle. So you have to have them call the office on day 1, and then 2 days later get their blood drawn. This one is falling out of favor somewhat for partly that reason, but it's also very variable. Antral follicle count is done at the same time, and it's most interpretable on cycle day 3. Everyone has antral follicles the entire menstrual cycle, so it's not like if you do an antral follicle count some other time, you won't get some information. It's just most informational when you're not right about to ovulate or you haven't recently ovulated. But this is an interesting picture of an ovary. The ovary itself is this whole circle here, and then all of these follicles clustered around the outside are antral follicles. So they are a unit that has an egg inside, granulosa cells, and then theca cells around the outside, and that black that you're seeing is the fluid that it has collected in the middle. Antral follicles are between 2 and 10 millimeters in size, and then one of these will get chosen to grow large and be the one to ovulate for the cycle, and the rest of them actually go away. So somehow, and we don't totally know how, the ovary knows whether it has a big supply of eggs left or not. And so when it has a big supply of eggs, it just starts, waking a bunch of these primordial follicles up every month, and it's sort of this constant cycling process. But as the number of follicles that you have diminishes, ovary knows it, and so it doesn't wake up as many of them per month anymore. And because of that mechanism, I can use the number of follicles I see growing on your ovary as a way to get an idea of whether you're working with a high egg supply or a low egg supply. So I can never tell you how many, but I can tell you, good, bad, average. And then the anti-Mullerian hormone is actually being produced by those small growing follicles we were just talking about. So especially the ones that are not quite up to the size where I can see them on the ultrasound, but they're getting there, they're going to be there soon. Those are making AMH, and so the more of those I have that are growing, the higher your AMH level is going to be in your blood work, and so that is also a nice way to get an idea, like big egg supply, or is it getting low? And so in studies looking at in vitro fertilization in particular, having a low AMH can tell me that I've got a patient that might have a bad response or a low response when I give them medicines to try to stimulate their ovaries. They may end up with poor embryo quality, but again, their age tells me more about that. And then it just so happens that if you are older in your reproductive years, you're more likely to have a low AMH. And then they may not be as likely to be pregnant with IVF. So there is not really any specific treatment for reversing the process of diminished ovarian reserve or low egg supply. There's not really any way to halt that process. Even being on Depo-Provera, continuous birth control pills for years and years and years, that process is still going on. So you're always waking up primordial follicles and they're always cycling through. So you actually aren't able to save things for later by doing that. But when patients come in and they've gotten really to the very far end of their egg supply, we do still have some options to try for pregnancy. It might just not be a pregnancy that's genetically related to them, because they can use eggs from an egg donor, and usually that's going to be somebody who's in their mid-20s and is recruited through an agency, who has a really good egg supply, or a donor embryo, which those are usually created during fertility treatments for infertile couples, and then those couples have finished having all of their babies that they're planning to have, but they still have embryos left over and frozen, and so they get donated, and so those can be used as well. And then the patient's chance of pregnancy is going to depend on how old that female partner was when those embryos got created. So it's a little higher chance with egg donor, but both are available options. And a few years ago, I think it was about 5 years ago, the American Society for Reproductive Medicine actually put out a statement as far as like up to what age do they support doing this treatment for women. So you can actually be postmenopausal in your late 40s, early 50s, and still actually take hormones, use a donated embryo, or create an embryo with your partner's sperm and a donated egg, and we can implant it in the uterus and it can grow. And as long as you are healthy, that is probably fine. People in their 50s are more likely to have medical comorbidities, so diabetes, obesity, hypertension, all those things go up, and so they may not be a good candidate for safe pregnancy, but their uterus is capable. You just have to supply them with hormones. So those candidates have to be screened really closely. And this is just a graph to kind of demonstrate, what's your chance of pregnancy by female age doing IVF with your own eggs versus donor eggs. Because donor eggs are going to pretty much always come from someone who's around the same age, mid-20s. And so it doesn't really change no matter how old the person carrying the baby is. It's not the uterus that ages and causes that decrease in fertility, it's the ovaries and the egg supply. So moving on to fallopian tube obstruction, so tubal factor infertility, probably not quite a third of the time when we do that female workup, but higher risk again if you have a history of prior sexually transmitted infections, again in particular chlamydia or gonorrhea, because those can often co-occur, pelvic inflammatory disease, pelvic surgery, prior ectopic pregnancy. Because if those have bleeding and rupture, then they can actually cause local inflammation in the pelvis as well, which can cause the fallopian tubes to scar. And so pretty much what happens when a fallopian tube gets inflamed is those little fimbriated ends, and I like to use my arms to tell patients about fallopian tubes. So they will actually stick to each other, And then when the inflammation calms down and it heals, that healing process will turn this into a nice smooth cyst, more or less. And so now the fallopian tube isn't open anymore, and the ovary is hanging out here, and so when it ovulates, that tube can't pick it up anymore. So the egg and the sperm, which is coming up this way, are never going to find each other. So tests for fallopian tube patency, there's two main ones. One is called a hysterosalpingogram, and this is a fluoroscopic test. It's often done outpatient. We have an x-ray room in the office to do this. We use radiopaque dye, actually pass it through the cervix into the uterus, and from there it should be able to go out to the fallopian tubes and show me whether they're open or not. And so it's a really good test if it looks like your tubes are open. If it looks like they're open, they're probably open. If it looks like they're blocked, they actually might not be. And so depending where the blockage looks like it is, I might have to go and do another test to confirm. And so that could be laparoscopy with something called chromoperturbation. And I've got pictures of these in a second. But this requires surgery, general anesthesia, laparoscopy, and then we actually put blue dye through the fallopian tubes while looking at them directly with that camera in the abdomen. And that if I see blue dye come out the end, then I know the tube is open. So this is showing a hysterosalpingogram. So this is the little catheter that is being used to put dye inside the uterus. And remember that cavity is kind of triangular shaped here. I think it's tilted toward us a little bit in this image. But you can see that the dye traveled along the length of the fallopian tube, got to the end of it, and then it couldn't go anywhere. This should have spilled out and kind of faded around. It just collected in the end. So that fimbriated end did what I was just saying and got scarred over, and so now this patient has a hydrosalpinx, which is a big collection of fluid in the end of that tube. So that is a non-functional tube. And then this one doesn't look as fat, but it doesn't look like it's spilled either. And this is actually a picture of a laparoscopy showing a patient with a hydrosalpinx. So uterus is here, and then the tube is traveling all along here, and then you can see it almost looks like a cyst, but that's where all the blue dye has gone, and then it couldn't spill out anywhere. And this is what it should have looked like. So the fimbria always get drawn in pictures like they're really fingers, but they're actually kind of this fleshy mess, and then there's a little bit of an opening right there. And they're important because there's, again, we don't totally know the signal, but they have a chemical communication between the ends of the tube and the egg, and so that's part of what helps the tube identify where the egg is and pick it up. So treatment for tubal obstruction. Surgeries exist for this, but they don't work very well, so this is not usually what we do. Usually we do in vitro fertilization, and so that could be a whole separate hour-long talk about how it works, but the idea is that you take those injectable gonadotropins, the FSH and LH that we were talking about, high doses, get as many of those follicles that are small antral follicles growing to all stimulate and grow large, and then at the end of that process, which takes about a week and a half, we have the patient get an egg retrieval, which is a procedure done in the office under sedation, where we do an ultrasound, put a needle guide on it, actually stick the needle right into the ovary, right into those follicles, suck out the fluid, the eggs come with the fluid, get them into the laboratory, and then get a sperm sample from the partner and fertilize them in the lab. So we're using the lab as the patient's fallopian tubes. We don't need the tubes anymore for this. And so this picture is showing one of the ways that we can fertilize in the lab. So this is an egg being held in place by this holding pipette, and then there's a tiny microneedle injecting a sperm right into it. So that's one way. And then the other way is to actually just put egg and sperm together in the dish. That's where the term in vitro fertilization comes from. So then uterine abnormalities, HSG, that test we just talked about with the dye in the fallopian tubes, actually shows me the shape of the endometrial cavity and whether there's anything sticking into the space, like a polyp or a fibroid in the lining. And so that can be a good evaluation for the uterus as well. We usually like to combine that with ultrasound, or you can even do ultrasound where we put saline into the uterus, and hysteroscopy is kind of the most definitive way, and it's usually what we do if we think we saw something on these other tests to try to treat it, like take the polyp out. So hysteroscopy is putting a camera through the cervix right into the uterus, and this is usually done with a patient asleep also. And then you can put instruments through that can grab the polyp. So this is showing this has different names. So saline infusion sonogram or SIS, sonohysteroscopy or SHG, it's all the same thing. It's putting saline into the cavity in the uterus. And so this outer part is the lining, but then sticking into this space, particularly that little gray blob, that's a polyp. So that shouldn't be there. And this is showing a 3D image of the same test in a different patient who has a much larger lesion sticking into their cavity, and that's actually nice and round, so that's likely a fibroid. And so those can both be treated with hysteroscopy. And then for male infertility, we know that up to, again, about a third of couples are going to be affected by male factor as well. And so, thinking about it as kind of a third, ovulatory problems versus tubal problems versus male factor, knowing that they can co-occur in couples. So in order to test for male infertility, we're going to get a semen analysis. We're going to test volume, concentration, which is the number of million sperm per milliliter, motility, which is the percent of them that are swimming and moving, and then morphology, which is the most specialized test, and so having an experienced lab actually do your semen analysis is important for this one. They stain the sperm onto a slide and actually grade it under the microscope for the exact size of the head and the midpiece and the tail, and are there two heads or two tails, and is it bent, and all sorts of different issues that can arise. And so sperm has to be super perfectly shaped to get yes, this is a normal sperm, and so that one usually sounds pretty low when I tell my guys their results. So if it's 4% of them are normal or higher, then they're fine. And I'll often get numbers like 2% or 3%. If everything else is okay, I don't usually worry about that one too much, but it's a very picky score, and it takes about a week to come back. And then we can calculate from all this the total mobile count, which is the total number of swimming sperm in the whole sample. So on my guys, I'm going to take a full history as well, actually. So it's nice when I've got both members of my couple, and again, all of this is very specific to heterosexual couples. But so again, coital frequency and timing, any sexual dysfunction, whether they've had children with a prior relationship, any childhood illnesses. As we're getting into the age of measles and mumps coming back more, this becomes more important. So mumps can actually cause a spiral orchitis that can cause lifelong scarring in the testicle and can actually decrease sperm counts dramatically and lead to infertility. Cryptorchidism, were their testicles undescended when they were born? Do they have any medical illnesses, in particular diabetes? I would worry about for sexual dysfunction, as well as something called retrograde ejaculation, where instead of coming forward through the urethra, it actually backs up into the bladder. So hard to get pregnant that way too. Previous surgeries. I have one patient who didn't have any sperm in his ejaculate entirely because he had bilateral inguinal hernia repairs, and it totally obstructed his vas deferens, and so they couldn't go past there. So things like that can happen. Are they taking testosterone or anabolic steroids of any type? I also run into surreptitious use, so they may or may not tell me at the first visit, but I might find out later when they've got a terrible sperm count, and now I want them to go to the urologist and have a testicle exam and everything. So it usually comes out eventually that testosterone use has actually been formally studied as a possibility for male birth control. Because it's kind of like what happens when you are a female and you take estrogen and progesterone, it suppresses your hypothalamic pituitary axis. And so same thing happens with men when you take testosterone, and so now they're not making enough LH to tell their testicle to make its own testosterone and to do sperm production at a normal rate. And so stopping testosterone is important, and it's often somewhat reversible, but not always. And it's not always going to reverse to be totally normal. So that was kind of a bummer when they didn't know that or were prescribed it by a provider who doesn't do what I do. Sexual history is important on the men as well. STD exposure, what they do for a living, do they have likelihood of toxin exposure at work, and very similar family history. And in the males in particular, I hear about cystic fibrosis because cystic fibrosis, even carriers can have congenital bilateral absence of the vas deferens, and so they can also have a functional obstruction even if their sperm production is normal. So this is just to show you guys what the current normal cutoffs are that we use to determine whether semen analysis is normal. So concentration needs to be at least 15 million per milliliter, and motility ideally needs to be at least 40% of them swimming, like we talked about, 4% normal forms on the sperm morphology. And so for male factor infertility, because I am not someone who is as trained on the male exam. I usually send them to my reproductive urologist, so if you have one of those, that's fantastic. Urologist or primary care physician, whoever does those exams more often. If you are comfortable, perfect. But we want to look at like testicular volume, palpate the vas deferens, check for varicocele, which is a collection of dilated veins within the scrotum, and then they'll get a whole panel of hormone testing when they go see my urologist. They do testosterone, estradiol, LH, FSH, TSH, prolactin, all those pituitary hormones, because just like in women, having a problem that's related to your pituitary hormones can affect your reproductive system. If your male factor is kind of more mild, meaning you have technically low counts but enough to work with, then we can do intrauterine insemination and have a pretty reasonable chance of helping their partner to be pregnant. So we time this with their ovulation, and so on the day that the female partner is ovulating, the male partner is going to collect a sperm sample for me in my lab. I'm going to take it and they're going to wash it. So they're going to put culture medium with it, kind of centrifuge it to get just the sperm cells, and then take those and put them in a little bit of culture medium that doesn't like irritate the uterus. Load it up in this little syringe, and there's a little catheter that's going right into the uterus through the cervix here, and that bypasses that cervical mucus. It helps a whole lot more of the sperms actually make it out into the fallopian tube. That cervical mucus is by design a pretty good filter, and sperm have to work really pretty hard to make it up through there. So not as many of them as you would think do make it out into the tube. We can make a whole lot more of them make the trip easily by doing this procedure. And then if their counts are present but way too low to have a reasonable chance of this working, because I need at least 1 million good swimmers in this sample to have a reasonable chance of telling a couple, I think this might work. But reasonable chance we consider, 10, 12%. It's not high, it's just higher than trying on their own. So a lot of people have to do this multiple times. But IVF is also a good option for that male factor infertility, and that's partly because of that picture I showed you where we have the one egg and then you just inject a sperm into it. So I might very reasonably get between 10 and 30 eggs from my female, and so then I only need between 10 and 30 sperm cells from my male partner. So I don't need nearly as many. I don't need millions. I don't need hundreds of thousands. I need like maybe 50. And so if I'm just taking one and injecting each egg with it, then ICSI, intracytoplasmic sperm injection is what that's called, is a really nice way to get around that really severe male factor too. And then the other thing I didn't actually put on here, but it's kind of interesting. So those guys I mentioned that have obstruction, my urologist can actually go in and do a surgical procedure for them where they go and get the sperm directly from the testicle or from the epididymis, which is kind of the storage site. And so then I can take that to the IVF lab. The female partner can do IVF, get eggs into the lab, and we can take that sperm from that urology procedure from my guy and inject them that way too. And so that can get around that congenital absence of the vas deferens or that obstructed vas deferens from the surgery. So that's a nice option to have. So indications to refer a couple to someone who can do the workup or to initiate the workup. Any couple that's been trying for over 12 months. If the female is over age 35, as you saw, their chances start to decrease, so it's very reasonable to do a workup for them after trying for 6 months, especially since you know in 6 months to a year her fertility status is not even going to be as good as it is the day that she's in your office. If they have an abnormal semen analysis or you have some reason to believe that the male might have male factor. If she has really long-standing irregular periods or comes off her birth control and periods are irregular, they don't need to try for a year. So you already know she's not ovulating, she's not going to be able to get pregnant without medicine to help her to ovulate. So you don't have to put that couple through waiting for a whole year of trying, never knowing exactly when to have intercourse, and then go see somebody. They can go see somebody right away. They can have the evaluation right away. If you suspect PCOS, kind of same theme. If they have a terrible history of pelvic inflammatory disease and hospitalizations or some other reason, kink for tubes might be blocked, reasonable to go ahead and refer or evaluate. And then some OBGYNs who are general practitioners and don't do what I do necessarily They see a lot of couples with infertility. Some of them are comfortable going ahead and starting kind of that least expensive, milder therapy like Clomid. And then if they've not had any success after 3 cycles, they'll often send them along to us. So, questions about all that? Yes?
I had kind of 2 questions actually.
Yeah.
So since we're seeing increasing sexually transmitted infections, do you predict there to be a bigger burden in fertility in upcoming years?
I mean, I feel like I see tubal factor quite a bit already, so quite possibly. What also seems to be a big contributor right now is the fact that, like, I don't know if you guys heard the birth rate stats that came out a few months ago, but the only female age group where the birth rate is going up right now is between 35 and 40, and so they think the pattern has become that a lot of women are finishing school and at least getting their career going before even trying for pregnancy, and that's certainly our experience in our office too, and so they're more likely to wind up in a fertility clinic as well. So I think that's been a bigger contributor, honestly, but yeah, you're right, we very well may see a big influx, but I don't feel like that's even rare now. Yes?
We just spoke about endometriosis earlier today, so I'm sure you see some of these patients in your clinic. What is your first approach usually for those patients? I'm sure it varies, but
kind of depends on whether they're having pain.
Okay.
So for me, as a fertility provider, I want to know from this patient, is your pain kind of your bigger priority, or is trying to have a family as quickly as you can a bigger priority? And so it's more often in my office that it's trying to have a family.
Sure.
So I know it's important for that person that I know that their tubes are open. That's going to depend what fertility treatment that I offer to them. But often we'll actually just launch into really aggressive fertility treatment because the way endometriosis is hormonally responsive, when you've got that placenta, your progesterone, estrogen are really high, actually helps those lesions regress. And so often people will feel better when they're pregnant. And some of the really good hormonal therapies that help with pain for endometriosis, which can really be good to continue even after you've done surgery for endometriosis to help keep them from coming back, all of those are contraindicated when you're trying for pregnancy. Whether your birth control pills or your progestin-only therapy or your GnRH agonist, all of that is not compatible with what I do. So we have a chat about goals and then go from there.
Thank you.
Yeah. All right.
I have one.
Yes.
So do y'all, once a patient conceives, do y'all follow the patient in your office, or do they then go to an...
We follow them for a little bit. So, miscarriage rates are going to depend somewhat on female age. In general, numbers tend to run, depends what you read, between 15 and 25%. And so it's really frustrating for patients if, we help them get pregnant and then immediately go see your OBGYN, and then they get diagnosed immediately with a miscarriage and come right back. So we actually want to care for them during that highest risk time for the miscarriage. So we tend to follow them up until about 9 or 10 weeks of pregnancy. And if things are going well, then we graduate them onto the OBGYN for the remainder of their OB care. All right. Should we take a little break?